important thing is that when I take the cost of the test and I multiply it by 6 million people and I add the cost of the therapy, the total cost has to be reasonable. Well, here are all the tests. Do any of them work? Well, let's do the math first. See if you can pay for it. Percent in thalliums. Lots of people want you to do percent in thalliums. If you take a $1,500 test, you multiply it by 6 million people, you get $9 billion. 37% are positive, and you do cabbages for $20,000 a piece. You end up spending $44 billion on surgery for a combined cost of $53 billion. You reduce the risk about 50%, so you spent $4 million per life saved. Now, I admit, if you order 6 million p-thals, you're going to get a discount, but it's still a huge number. Okay? Does this work? We did a study in the early 90s where we took patients for vascular surgery, gave them dipyridamole thalliums, and we did something you can only do at a VA. We didn't bother looking at the test. We just tested them and then operated. And the reason you do this is that if you actually look at the test, people get so scared they cancel surgery. They give some drug, they do something or other. But what we found was there was no association between the redistribution defects and ischemia, infarction, MIs, death, anything. The test told you nothing about what was going to happen to the patients. This study was criticized because it's sort of small, 60 people, but it was repeated by Barron, who's in France, and he did dipyridamole thalliums on 457 people coming for vascular surgery, and what he found was that this test told him absolutely nothing about what was going to happen. There was no predictive value. Now, he said it in French, but it's still true. This test doesn't predict what's going to happen. Next. Why is this? These tests are designed to tell you who is going to have a positive coronary angiogram. Okay? They tell you if there's a flow-limiting lesion. Here's an angiogram, which is perfectly normal. Here's a lesion right here, which is ready to rupture. There's fat and liquid stuff here. Just a little bit down the vessel, it's perfectly normal. This person would pass both the dipyridamole thallium and the coronary angiogram despite having this lesion that's ready to rupture. These tests detect this lesion, but these two are still dangerous. Okay? So let's think about tests. Can they predict perioperative cardiac morbidity? Can you get one that's cheap, effective? Can you bill for it? Can you do something with the data? Well, let's look at some of this. Here are all the tests. Which of them are proven? Well, before we do that, let's see if we could actually do something if we had a great test. Suppose I invented a test. Well, we've got 500,000 cardiac cases a year in the U.S. If I decide to add 2 million more operations, I'm going to need a lot more surgeons. Okay? Moreover, the risk of major surgery before the cabbage is about 6% with 3% mortality. But the risk of the cabbage itself has a 3% mortality and a 6% neurologic event rate. 3% strokes, 3% other events. The risk of major surgery after the cabbage is about half. And when you add the risk of the cabbage to the risk of the subsequent operation, you get back to where you started from. Okay? Here's the risk of cabbages. Death, 3.2, stroke, 3, other neurologic events, 3, neurocognitive defects. 95% of people that have an on-pump cabbage get a neurocognitive defect. 10% go to a nursing home, at least one complication, all of them. Now, I make my living as a cardiac anesthesiologist, but the truth is that all of the people coming for surgery get a complication. Let's talk about PTCAs for a second. Here's a paper which I don't recommend you repeat.